Hello, welcome to the Medical Licentiate Emerson channel. Today we will go through ABG. Arterial blood gas (ABG) interpretation is something that can be difficult to grasp initially. We've been there. We've created this tutorial video, which aims to provide a structured approach to ABG interpretation whilst also increasing your understanding of each result's relevance. The real value of an ABG comes from its ability to provide a near-immediate reflection of the physiology of your patient, allowing you to recognize and treat pathology more rapidly. Reference range is as follows. pH 7.35–7.45. Partial pressure of carbon dioxide PaCO2 4.76.0 kilopascals or 35.245 millimeters of mercury. Partial pressure of oxygen PaO2 11 to 13 kPa or 82.597.5 millimeters of mercury. Bicarbonate HCO3 22 to 26 MEq/L. Base excess B -2 to +2 mmol/L. Oxygen saturations as follows. 94–100%. pH 7.35–7.45. PaCO2 4.76.0 kilopascals, 35.245 millimeters of mercury. PaO2 11–13 kilopascals, 82.597.5 millimeters of mercury. HCO3 22 to 26 MEq/L. Base excess B -2 to +2 mmol/L. Before getting stuck into the details of the analysis, it's important to look at the patient's current clinical status or clinical condition, as this provides essential context to the ABG result. Below are a few examples to demonstrate how important context is when interpreting an ABG. Normal, PaO2 in a patient on high-flow oxygen. This is abnormal as you would expect the patient to have a PaO2 well above the normal range with this level of oxygen therapy. Normal, PaCO2 in a hypoxic asthmatic patient. A sign they are tiring and need ITU intervention. Very low, PaO2 in a patient who looks completely well, is not short of breath and has normal O2 saturations. This is likely a venous sample. Hope we are together so far, and if you haven't subscribed, please subscribe to the channel. Your first question when looking at the ABG should be, is this patient hypoxic? As hypoxia is the most immediate threat to life. Partial pressure of O2 should be greater than 10 kilopascals, 75 millimeters of mercury, when oxygenating on room air in a healthy patient. If the patient is receiving oxygen therapy, their partial pressure of O2 should be approximately 10 kilopascals less than the inspired concentration FiO2, so a patient on 40% oxygen would be expected to have a PaO2 of approximately 30 kilopascals, 225 millimeters of mercury. Oxygen delivery devices and flow rates. A common question is, what percentage of oxygen does this device deliver at a given flow rate? Below is a quick reference guide, providing some approximate values for the various oxygen delivery devices and flow rates you'll come across in practice. Nasal cannulae. As with all oxygen delivery devices, there is a significant amount of variability depending on the patient's breathing rate, depth and how well the oxygen delivery device is fitted. Below are some guides to various oxygen flow rates and the approximate percentage of oxygen delivered. 1 L per minute 24%. 2 L min 28%. 3 L min 32%. 4 L per minute 36%. I know the data is flowing at a faster pace, but feel free to rewind the video and give us a like. Simple face mask. The oxygen delivery of simple face masks is highly variable depending upon oxygen flow rate, the quality of the mask fit, the patient's respiratory rate and their tidal volume. Simple face masks can deliver a maximum FiO2 of approximately 40%–60% at a flow rate of 15 L per minute. These masks should not be used with flow rates less than 5 L per minute. We are now done with a simple face mask. Next. Reservoir mask, also known as a non-rebreather mask. Reservoir masks deliver oxygen at concentrations between 60% and 90% when used at a flow rate of 10 to 15 L per minute. The concentration is not accurate and will depend on the flow of oxygen as well as the patient's breathing pattern. These masks are most suitable for trauma and emergency use where carbon dioxide retention is unlikely. Hope we are together. Venturi masks. A Venturi mask will give an accurate concentration of oxygen to the patient regardless of the oxygen flow rate. The minimum suggested flow rate is written on each. Venturi masks are available in the following concentrations: 24%, 28%, 35%, 40% and 60%. They are suitable for all patients needing a known concentration of oxygen, but 24% and 28% Venturi masks are particularly suited to those at risk of carbon dioxide retention, e.g. patients with chronic obstructive pulmonary disease. Hypoxemia. If partial pressure of O2 is less than 10 kPa, 75 mm of mercury, on air, a patient is considered hypoxemic. If partial pressure of O2 is less than 8 kPa, 60 mm of mercury, on air, a patient is considered severely hypoxemic and in respiratory failure. Type 1 vs Type 2 respiratory failure. Type 1 respiratory failure involves hypoxemia, PaO2 less than 8 kPa, 60 mm of mercury, with normocapnia, PaO2 less than 6.0 kPa, 45 mm of mercury. Type 2 respiratory failure involves hypoxemia, PaO2 less than 8 kPa, 60 mm of mercury, with hypercapnia, PaO2 greater than 6.0 kPa, 45 mm of mercury. Let's now go in details of each type mentioned. Type 1 respiratory failure. Type 1 respiratory failure involves hypoxemia, partial pressure of O2 less than 8 kPa, 60 mm of mercury, with normocapnia, partial pressure of CO2 less than 6.0 kPa, 45 mm of mercury. It occurs as a result of ventilation-perfusion VQ mismatch. The volume of air flowing in and out of the lungs is not matched with the flow of blood to the lung tissue. As a result of the VQ mismatch, partial pressure of O2 falls and partial pressure of CO2 rises. The rise in partial pressure of CO2 rapidly triggers an increase in a patient's overall alveolar ventilation, which corrects the party pressure of CO2 but not the partial pressure of O2 due to the different shape of the CO2 and O2 dissociation curves. The end result is hypoxemia, partial pressure of O2 less than 8 kPa, 60 mm of mercury, with normocapnia, partial pressure of CO2 less than 6.0 kPa, 45 mm of mercury. Examples of VQ mismatch include reduced ventilation and normal perfusion, e.g. pulmonary edema, bronchoconstriction. Reduced perfusion with normal ventilation, e.g. pulmonary embolism. Then for Type 2 respiratory failure. Please know that Type 2 respiratory failure involves hypoxemia, PaO2 is less than 8 kPa, 60 mm of mercury, with hypercapnia, PaO2 greater than 6.0 kPa, 45 mm of mercury. It occurs as a result of alveolar hypoventilation, which prevents the patient from being able to adequately oxygenate and eliminate CO2 from their blood. Hypoventilation can occur for a number of reasons including increased resistance as a result of airway obstruction, e.g. COPD. Reduced compliance of the lung tissue, chest wall, e.g. pneumonia, rib fractures, obesity. Reduced strength of the respiratory muscles, e.g. Guillain-Barré, motor neuron disease. Drugs acting on the respiratory center reducing overall ventilation, e.g. opiates. Now let's go through pH. Seemingly small abnormalities in pH have very significant and wide-spanning effects on the physiology of the human body. Therefore, paying close attention to pH abnormalities is essential. So we need to ask ourselves, is the pH normal, acidotic or alkalotic? Acidotic, pH less than 7.35. Normal, pH 7.35-7.45. Alkalotic, pH greater than 7.45. We need to consider the driving force behind the change in pH. Broadly speaking, the causes can be either metabolic or respiratory. The changes in pH are caused by an imbalance in the CO2, respiratory, or HCO3, metabolic. These work as buffers to keep the pH within a set range, and when there is an abnormality in either of these, the pH will be outside of the normal range. As a result, when an ABG demonstrates alkalosis or acidosis, you need to then begin considering what is driving this abnormality by moving through the next few steps of this tutorial video. At this point, prior to assessing the CO2, you already know the pH and the PaO2. So for example, you may know your patient's pH is abnormal but you don't yet know the underlying cause. It could be caused by the respiratory system, abnormal level of CO2, or it could be metabolically driven, abnormal level of HCO3. Looking at the level of CO2 quickly helps rule in or out the respiratory system as the cause for the derangement in pH. Let us now look at the table. pH CO2 HCO3. In respiratory acidosis the pH is low, carbon dioxide is high, then bicarbonate is normal. Then in respiratory alkalosis pH is high, then carbon dioxide is low, bicarbonate is also normal. In respiratory acidosis with metabolic compensation, the pH is low or normal, carbon dioxide is high, then bicarbonate is high. Then finally in respiratory alkalosis with metabolic compensation, the pH is high or normal, carbon dioxide is low, and bicarbonate is also low. Next we will look at the underlying biochemistry. As in, why does it happen like this? What's the underlying biochemistry? Underlying biochemistry. CO2 binds with H2O and forms carbonic acid, H2CO3, which will decrease pH. When a patient is retaining CO2 the blood will, therefore, become more acidic from the increased concentration of carbonic acid. When a patient is blowing off CO2 there is less of it in the system and, as a result, the patient's blood will become less acidotic and more alkalotic. Look at the carbonic equation. Carbon dioxide plus water gives off carbonic acid which can further give off bicarbonate ion and hydrogen ion. This equation can occur vice versa. The idea of compensation is that the body can try and adjust other buffers to keep the pH within the normal range. If the cause of the pH imbalance is from the respiratory system, the body can adjust the HCO3 to counterbalance the pH abnormality, bringing it closer to the normal range. This works the other way around as well. If the cause of a pH imbalance is metabolic, the respiratory system can try and compensate by either retaining or blowing off CO2 to counterbalance the metabolic problem, via increasing or decreasing alveolar ventilation. So we need to ask ourselves, is the CO2 normal or abnormal? If abnormal, does this abnormality fit with the current pH? E.g., if the CO2 is high, it would make sense that the pH was low, suggesting this was more likely a respiratory acidosis. If the abnormality in CO2 doesn't make sense as the cause of the pH abnormality, e.g. normal or reduced CO2 and reduced pH, it would suggest that the underlying cause for the pH abnormality is metabolic. End of part 1. Thank you for watching. Please subscribe and give us a like and comment. Next is part 2. In part 2 we will continue with bicarbonate and going to base excess and the like. Please turn into part 2 as well. This is the second continuation part for ABG interpretation. Part 2 for short, where we will continue from where we left off. We now know the pH and whether the underlying problem is metabolic or respiratory in nature from the CO2 level. Piecing this information together with the bicarbonate, HCO3 for short, we can complete the picture. Bicarbonate, HCO3, is a base, which helps mop up acids, H+ ions. So when bicarbonate, HCO3, is raised the pH is increased as there are less free H+ ions, alkalosis. When bicarbonate, HCO3, is low the pH is decreased as there are more free H+ ions, acidosis. So we need to ask ourselves, is the HCO3 normal or abnormal? If abnormal, does this abnormality fit with the current pH, e.g. reduced HCO3 and acidosis? If the abnormality doesn't make sense as the cause for the deranged pH, it suggests the cause is more likely respiratory, which you should have already known from your assessment of CO2. Looking at the table, for metabolic acidosis, the pH is reduced, bicarbonate is reduced whilst carbon dioxide, CO2, is normal. Then metabolic alkalosis, pH is high, bicarbonate is high, then carbon dioxide is normal. For metabolic acidosis with respiratory compensation, pH is low, bicarbonate is low and carbon dioxide is low as well. Finally, for metabolic alkalosis with respiratory compensation, the pH is high, bicarbonate is high, and carbon dioxide is high as well. You may note that in each of these tables HCO3 and CO2 are both included, as it is important to look at each in the context of the other. That's the end of discussion on bicarbonate. Next we talk about base excess. The base excess is another surrogate marker of metabolic acidosis or alkalosis. A high base excess greater than +2 mmol/L indicates that there is a higher than normal amount of HCO3 in the blood, which may be due to a primary metabolic alkalosis or a compensated respiratory acidosis. A low base excess less than -2 mmol/L indicates that there is a lower than normal amount of HCO3 in the blood, suggesting either a primary metabolic acidosis or a compensated respiratory alkalosis. Compensation has been touched on already in the above sections. To clarify, we have made it simple below. Respiratory acidosis, alkalosis, changes in CO2, can be metabolically compensated by increasing or decreasing the levels of HCO3 in an attempt to move the pH closer to the normal range. Metabolic acidosis, alkalosis, changes in HCO3, can be compensated by the respiratory system retaining or blowing off CO2 in an attempt to move the pH closer to the normal range. Rate of compensation. Respiratory compensation for a metabolic disorder can occur quickly by either increasing or decreasing alveolar ventilation to blow off more CO2, increased pH, or retain more CO2, reduced pH. Metabolic compensation for a respiratory disorder, however, takes at least a few days to occur as it requires the kidneys to either reduce HCO3 production, to decrease pH, or increase HCO3 production, to increase pH. As a result, if you see evidence of metabolic compensation for a respiratory disorder, e.g. increased HCO3 base excess in a patient with COPD and CO2 retention, you can assume that the respiratory derangement has been ongoing for at least a few days, if not more. It's important to note that overcompensation should never occur and, therefore, if you see something that resembles this, you should consider other pathologies driving the change, e.g. a mixed acid-base disorder. It's worth mentioning that it is possible to have a mixed acidosis or alkalosis, e.g. respiratory and metabolic acidosis, respiratory and metabolic alkalosis. In these circumstances, the CO2 and HCO3 will be moving in opposite directions, e.g. increased CO2, reduced HCO3 in mixed respiratory and metabolic acidosis. Treatment is directed towards correcting each primary acid-base disturbance. You can see some causes of mixed acidosis and alkalosis in the next slides. Hope you are enjoying the data so far. And I hope I'm not too fast. If I am too far, please feel free to mention it in the comments section. So far we have discussed how to determine what the acid-base disturbance is. Once we have this established, we need to consider the underlying pathology that is driving this disturbance. Causes are 1. Respiratory acidosis. 2. Respiratory alkalosis. 3. Metabolic acidosis. 4. Metabolic alkalosis. 5. Mixed respiratory and metabolic acidosis. 6. Mixed respiratory and metabolic alkalosis. Let's now look at them in details. Respiratory acidosis is caused by inadequate alveolar ventilation leading to CO2 retention. A respiratory acidosis would have the following characteristics on an ABG. Reduced pH. Increased CO2. Causes of respiratory acidosis include respiratory depression, e.g. opiates. Guillain-Barré. Paralysis leads to an inability to adequately ventilate. Asthma. Chronic obstructive pulmonary disease, COPD. Iatrogenic, incorrect mechanical ventilation settings. Respiratory alkalosis is caused by excessive alveolar ventilation, hyperventilation, resulting in more CO2 than normal being exhaled. As a result, PaCO2 is reduced and pH increases, causing alkalosis. A respiratory alkalosis would have the following characteristics on an ABG. Increased pH. Reduced CO2. Causes of respiratory alkalosis include acute anxiety, i.e. panic attack, pain, causing an increased respiratory rate, hypoxia, resulting in increased alveolar ventilation in an attempt to compensate. Pulmonary embolism, pneumothorax, iatrogenic, e.g. excessive mechanical ventilation. Metabolic acidosis can occur as a result of either increased acid production or acid ingestion, decreased acid excretion or rate of gastrointestinal and renal HCO3 loss. A metabolic acidosis would have the following characteristics on an ABG. Reduced pH, reduced HCO3, reduced B. Anion gap. The anion gap Ag is a derived variable primarily used for the evaluation of metabolic acidosis to determine the presence of unmeasured anions. To work out if the metabolic acidosis is due to increased acid production or ingestion versus decreased acid excretion or loss of HCO3, you can calculate the anion gap. The normal anion gap varies with different assays but is typically between 4 to 12 millimole per L. Anion gap formula. Anion gap equals Na plus, Cl plus HCO3. An increased anion gap indicates increased acid production or ingestion. Diabetic ketoacidosis, increased production. Lactic acidosis, increased production. Aspirin overdose, ingestion of acid. A decreased anion gap indicates decreased acid excretion or loss of HCO3. Gastrointestinal loss of HCO3, e.g. diarrhea, ileostomy, proximal colostomy. Renal tubular acidosis, retaining H+. Addison's disease, retaining H+. Metabolic alkalosis occurs as a result of decreased hydrogen ion concentration, leading to increased bicarbonate, or alternatively a direct result of increased bicarbonate concentrations. A metabolic alkalosis would have the following characteristics on an ABG. Increased pH, increased HCO3, increased B. Causes of metabolic alkalosis include gastrointestinal loss of H+ ions, e.g. vomiting, diarrhea. Renal loss of H+ ions, e.g. loop and thiazide diuretics, heart failure, nephrotic syndrome, cirrhosis, Conn's syndrome. Iatrogenic, e.g. addition of excess alkali such as milk alkali syndrome. I hope we are together so far. A mixed respiratory and metabolic acidosis would have the following characteristics on an ABG. Reduced pH, increased CO2, reduced HCO3. Causes of mixed respiratory and metabolic acidosis include cardiac arrest, multi-organ failure. A mixed respiratory and metabolic alkalosis would have the following characteristics on an ABG. Increased pH, reduced CO2, increased HCO3. Causes of mixed respiratory and metabolic alkalosis. Liver cirrhosis in addition to diuretic use. Hyperemesis gravidarum. Excessive ventilation in COPD. That's the end of part 2. Thank you for watching. If you have not subscribed, please subscribe and hit the bell for notifications. Next is part 3, where we will cover 11 worked scenarios. Please stay tuned.